Thank you for inviting me here to give this lecture. This lecture I have divided into two parts. This is only the OATS, that is Oligo-Astheno-Teratozoospermia, how to manage. And the second would be the azoospermia. Okay, so that I'll take maybe 2 weeks later from now. So we know around male factor is responsible to about 50% of all your OPD patients, whether directly or indirectly. Directly, it is about 30%, and indirectly associated with unexplained infertility, PCOS, tubal blockage. So it becomes up to 50%. This is WHO 2021 criteria, where the sperm concentration is now up to 16 million and total motile sperm count should be up to 39%, with rapid progressive motility about 30%. This is WHO 21 with strict morphological criteria of 4%. Now, when you do not find any sperms in the semen sample in initial preparation, what you should do is the semen sample should be centrifuged at 30,000 RPM for 15 minutes and the palate should be examined under high magnification. You may find viable sperm in 35% of the patient. Then when you get one abnormal report, it has to be confirmed from two reports from a standardized semen analysis laboratory which has a counting chamber and a microscope and a person who is experienced in this field, rather than sending to anybody, any lab, because on this report you are going to decide your further course of action. So this should be at least 4 weeks apart. Now I prefer 2 to 3 days abstinence rather than 2 to 7 days. That gives a little better report. As I explain you later during the presentation, you will understand. Now, why am important for this particular thing from a laboratory? Because many infertility consultants will vouch with me that patients are referred for IUI after giving clomiphene or letrozole to the woman. Her laparoscopy is done, endometriosis removed, fibroid removed, and his previous count is showing 35 million. Now the count is not done. When they come to our center, we find the count is actually 5 million. So what has gone wrong is we have completely missed the male factor and we have over treated the female. So this to avoid has to be done at least 4 weeks apart. Now you have given a treatment to the patient. We know one spermatogenetic cycle, testicular phase is up to 63 days. From there, testes to epididymis to ejaculatory duct is up to 21 days. So we'll have to wait for judging your response to the treatment for 21 days. Now, semen analysis is only a conventional diagnostic test. It cannot define this is infertile and this is fertile. Means a count of 5 million also can have 2 children and count of 100 million will go into unexplained infertility. Up to 40% of the men can show infertile, a man can show a normal semen analysis. Hence, we need to identify a test which is called as total motile sperm count, in which we take the volume of the sperm and total number of percentage motility of the sperm. So pre-wash count at least has to be 5 million pre-wash. Then only you can consider for IUI. Anything less than pre-wash count less than 5 million, patient should be re-evaluated for all the parameters, treatment given, simultaneously treatment of the female, that is optimization of gamete, and then after 3 months repeat the count. If it is gone more than 5 million, then only please consider for IUI or otherwise send her for further treatment. The same thing, post-wash count should be between 1 million to 5 million. Now again same, post-wash count more than 1 million can give you a good result, but I have not seen very good result. So do not spend too much time in a patient whose count is not, means severe OATS should be referred for further treatment. Now, local conditions of the male infertility can be varicocele, genitourinary infection like tuberculosis. This is very common in STDs or testicular trauma during childhood. Environmental list is very big: smoking, pesticide, radiation, excessive use of mobile, and local other conditions like radiation for cancer therapy, chemotherapy, diabetes, systemic diseases. So you have taken the history of the patient, past surgical history. Say patient gives the history that he during childhood had undescended testes, and at the age of 10 the testes were moved down. Now we know that by the time his epithelium, the seminiferous tubule, maybe must have been destroyed, and hence you cannot expect a very good result. Or medication history, maybe he's taking some antihypertensive medicine which may be interfering with his ejaculatory process. The physical examination, obviously secondary sexual characteristics, abdominal examination for obesity, surgical scars, genital examination, both standing and supine. Standing to see whether varicose vein grade 4, grade 3 can be seen very easily, or physically lying down palpation of vas epididymis for again presence of spermatic cord in patient with azoospermia, even a digital rectal examination to know your prostatic enlargement. Investigation, semen analysis, DNA fragmentation in all these conditions, and oxidative stress, which is not available in Indian scenario at the moment, or we are not doing this in our clinical practice. We are including only DNA fragment. Blood test, one has to do karyotyping for Y chromosome microdeletion with patient with severe OATS, and this will be covered in the next lecture. Radiographic things, total ultrasound when it's extreme obesity, extreme obesity, history of total surgery, transrectal to see whether he has seminal vesicles, MRI pituitary for blowing out hyperprolactin. So now how history helps, age. Male always thought he is the ring and the finger is the woman. Is not the case. Now anyone above the age of 45 also shows the sperm can have genetic abnormality as autism or some minor neurological abnormality in the children can be noticed in the men whose age is above 45, and with comorbidity like diabetes it can be as low as 40. If duration of marriage more than 5 years, well, we need to evaluate job profiles where heat or radiation can be injurious to the lower temperature, that is increasing the temperature of testes. The basic mechanism for good spermatogenesis is for having low temperature of the testes. That's why testes are outside. Lifestyle factors, smoking, alcohol, tobacco, indirect smoking, obesity, all these factors, and stress, which is important, may increase sperm DNA fragmentation and important cause of erectile dysfunction. History of erectile dysfunction and premature ejaculation needs to be discussed at length of time with patients, especially if the patient has diabetes mellitus or who is extremely stressed. These are the paternal changes that I was telling you: DNA damage, increased abnormal sperm, and increased genetic abnormality in the children and causing abortions in the. Now, one of the study way back in 2007 came out and saying that using mobile phone and putting in the trouser pocket can cause decreased sperm count, and because of electromagnetic radiation, heat, and ionizing radiation, and all these can cause testicular damage, affect quality, and DNA damages. And hence it was told that if you want to use mobile, then you should carry in your shirt pocket and not in the trouser pocket, so that when you die, you'll die of heart attack and not of infertility. Now, these are the men who are IT industry. They complain about difficulty in sexual relationship because of wrong timing. Most important, acquired importance, that is timely intercourse is very difficult, and lot of them can have premature ejaculation. Again, once you tell a man that his count is low, we need to work on his psychological aspect, because these are the things he may precipitate in the future life. So he has to be told that a man with 100 million count may last in the vagina maybe 1.5 minutes, and count with zero count may do an intercourse for 5 minutes. So they have not related to each other. So as I told you, count, motility, morphology. I request everybody to do viral markers before you attempt any procedure like IUI, because it is very important for your staff safety and for you for medical legal safety. Because once you do 3 IUIs and then before IVF you do HIV and if found to be positive, then he can say that it's because of your IUI this infection has happened. Age more than 35, sugars are must. It is must. According to me, sugars, blood pressure and lipid profile has to be done. Semen culture only if you find there are lots of round cells or pus cells which your analysis has shown. FSH in severe OATS, that is count less than 5 million or especially less than 1 million, to diagnose secondary testicular failure. Secondary testicular failure means the man previously may be having a good count and normal FSH, but over a period of time he's going down. So this is the man whose sperm can be cryopreserved rather than giving him completely into azoospermia. And in azoospermia, to rule out obstructive versus non-obstructive azoospermia. Serum testosterone under no circumstances to be used for male infertility, otherwise only in hypogonadotropic hypogonadism or low testosterone. Okay. Blood sugar, I told you, with recurrent pregnancy loss should be examined. Now, hormonal tests, testosterone, as I told you, for knowing the if the patient is impotent. FSH, I have told you, and prolactin. Now, if the semen analysis is normal, okay, either it could be psychological dysfunction where he is not been able to have intercourse, we need to identify that, or female factor evaluation. Low count, you need to do a sperm function test, serum FSH, blood sugar, rule out varicocele, and simultaneously evaluate the female part. No count or azoospermia, do FSH and physical examination to rule out congenital absence of vas. Color Doppler to rule out varicocele, but varicocele diagnosis by color Doppler sometimes can be overdiagnosed or underdiagnosed. It has to be physical examination in the light of male infertility, low sperm count, and apparently normal female, where varicocele correction can have a chance of spontaneous conception should be considered. Karyotyping in patients with severe OATS should be considered because inversion or translocation can happen. Y chromosome microdeletion, there are 3 areas. AZFA and B can cause azoospermia. If you are in the zone of AZFC, severe spermatogenetic failure, severe oligo-astheno-teratozoospermia. Now here I want to tell you something which is very important. You have a patient whose count is say less than 1 million. You have not done this test and you have done the FSH. For some reason, the FSH always comes normal. And you considering that FSH is normal, you will start him on clomiphene, antioxidant, everything. but this count is not going to improve because the cause is genetic, and such patient will only benefit by doing ICSI and by cryopreserving the semen sample. Remember, do not waste your time on doing further testing or medical management. Genetic testing, I told you, karyotyping, Y chromosome microdeletion prior to the diagnostic workup of in a non-obstructive azoospermia and severe OATS. A total ultrasound to be done when you have very obese patient with undescended testes, something that is very important, and history of surgery in the groin or previous hernia repair or mesh repair or evaluation of testicular mass. You are feeling some mass, or you want to diagnose atrophy, and varicocele is also can be diagnosed. Varicocele evaluation, it happens more in secondary infertility than primary infertility, as it is age related disorder. Means as you age, the varicocele will become more, and large visible palpable varicocele which is visible when patient is standing, and when he coughs you can see the impulse. Only this varicocele is important in terms of infertility improvement. Now, when you diagnose semen analysis, this is insufficient, being based on evaluation of sperm concentration, motility, morphology, which tools are poorly standardized because they keep changing the concentration. They are subjective, means I may find the count 5 million and somebody else may find count 2 million or 3 million or 8 million, and these are again not a powerful predictor of fertility. Hence, we need to do some tests called sperm function test, where may be indicated in all patients with abnormal semen analysis, advanced paternal age, infection, or when the semen analysis is normal but IVF is failed for some other reason, or hypoosmolar sperm function test to know motility of the sperm, and more important, the integrity of the cell membrane of the sperm tail, and most important to distinguish between immotile sperm and dead sperm. It can be immotile but live sperm. So hypoosmolar sperm function test, it can be immotile but live. When you do the test, the tail will curve. The embryologist can pick up this semen as the sperm, which we'll talk next time, or immotile dead sperm. Only you can do a trial TISA or use donor insemination. This is the curve tail. Curve tail. No curve tail. Dead sperm. Curve tail. Live sperm. So additional diagnostic tool can be DNA fragmentation index, and you can also have a genetic analysis of complete haploid genome, which is packed as a DNA material, and in infertile material, this lot of DNA inside the head gets fragmented because of incentric and eccentric factor. And this poor chromatin structure in the sperm is vulnerable to a DNA damage. Now, this is how it happens. Apoptosis and defective maturation because of incentric factor like diabetes mellitus, or these will produce a vulnerable sperm which can get damaged and cause sperm DNA fragmentation, leading to infertility, impaired reproductive outcome. That is, you see a good count but you don't get result in IUI, IVF or ICSI, or increased risk of abortion or birth defect. This is because of immature or abnormal sperms, because of same intrinsic factor, prolonged stasis in the epididymis, which will expose the sperm to ROS during the transit, and varicocele, which could cause again increased ROS production. External factors, all these environmental things can cause oxidative stress and lead to DNA damage. This is an example of oxidative stress in a donor which is less than 1. And if you see when the all semen parameters are abnormal, it is as high as 2.43. Now, when ROS is high and antioxidant capacity is low, then that's the treatment function that we think that is would help. Now, what happens such a sperm initiates a pregnancy? Either it will not initiate pregnancy, that is DNA, no DNA repair, fertilization failure can happen, or partial repair can happen, and abnormal offspring can happen, or very beautifully done, as we say, the oocyte will do the repair of this DNA abnormal, then a normal offspring can be found. Now, for this, the oocyte has to be really good and young. So typically, if you have a couple who's 35, both may not have that oocyte capacity to do this optimization in male infertility, and hence many times, even if the sperm count is low, because of advanced maternal age, we prefer to take a donor oocyte to give a better pregnancy outcome. So ROS levels have increased and disturb the sperm function, thereby leading to male infertility. Lifestyle, very easy to say, but very difficult to follow. Not more than 5 kgs they will lose. And these somehow, we always look at smoking, but this gutka, masheri, all these other things with lot of alcohol, lot of radiation exposure and good diet can help them. Moreover, antioxidants will help them to improve. So sperm quantity will depend on the DNA damage, the quality. Now DNA we know that is arranged in double helix structure like a ladder which is maintained correctly. If this ladder or the rugs are broken, then it will not function properly. Now, when you do a routine semen analysis, it is impossible to tell that whether this sperm is DNA fragmented, has little DNA or more DNA fragmented. So otherwise, normal semen analysis also can have high DNA fragmentation, and person with low sperm count can have very little DNA fragmentation. So I was explaining you in the initial stage, 5 million count also can initiate the pregnancy. Now, degree of DNA fragmentation can be very highly sensitive, and it may not be able to initiate the birth and can cause abnormal pregnancy, and which can cause abortion. So if this separation of these rugs less than 15% of the sperm, then it is considered as normal. If it is between 16 to 25%, it is fair potential, and more than 30%, it indicates the low fertility potential. So what does it indicate? Time required for natural pregnancy, they found, is more, and meta-analysis shows failure to achieve natural pregnancy if the DNA fragmentation is more than 30. Again, DNA fragmentation more than 30, decreased pregnancy rate, and negative results with IUI. That's why in male infertility, IUI does not give very good results. Systemic review failed to show significant association between sperm DNA fragmentation and ICSI. I will talk about it a little later, but it shows decreased pregnancy outcome and pregnancy rate. Again, meta-analysis, decrease sperm DNA fragmentation increases the live birth rate after IVF. And in IVF, what happens? You are subjecting both the gametes for prolonged culture. So you release the sperms and the oocyte in the petri dish for 24 hours for fertilization. which can cause oxidative stress, and hence ICSI is very good for male factor infertility. Now, this slide is something very, very important. When you have a short abstinence, sperm DNA fragmentation automatically reduces by 25%. Oral antioxidant therapy can be effective, ranging from 66 to 18 to 19%, depending upon type of antioxidant and type of abnormality. Varicocele, again 27%. When you use techniques like MAP, MC, PIXI, again it can reduce the DNA fragmentation. There are different schools of thought regarding this, because MC can visualize the sperm, but it doesn't visualize the DNA material. Swim up and swim down, or testicular sperm. Look at testicular sperm. It can reduce DNA fragmentation up to 80%. So, if you have a patient who has undergone 2 ICSI cycles with ejaculated sperm in a male factor, third cycle, one should give him a trial of testicular sperm rather than giving ejaculated sperm. You are likely to succeed very high. Now, why ROS damages the sperm? Because the plasma membrane of the sperm is rich in unsaturated fat, and cytoplasm contains low antioxidant capacity. That's why it has got more chances of getting damaged. Again, same protein damage, lipid peroxidation, apoptosis, and DNA damage. Apoptosis will cause Oligo-Spermia. Lipid peroxidation of the tail will cause Asthano. DNA damage will cause low pregnancy outcome. Now, we know all these things which are very, very easy to tell a patient, but we do not insist that you should stop smoking, then I'll start treatment. No, we don't do that. We just say you stop smoking and it will be better. Frequency of ejaculation. I've seen infinite number of patients coming for IUI with 10-15 days of abstinence. What result they are likely to get? Diabetes, we know it can cause abortion and congenital heart disease, psychological stress, and environmental radiation. This I will talk in the next. Treatment options. Antioxidants can decrease reactive oxygen species. Sperm vitalizer increases sperm motility. Nutritional supplements, big question mark. Antibiotics only if in infection, hormonal agent. Surgery, microsurgical varicocelectomy. Now, treatment option. Now, androgen, forget anti-estrogen. Idiopathic male infertility. So, anybody who's got a count between 5 and 15 million sperm count, FSH being normal, you treat them with clomiphene or tamoxifen. Clomiphene 50 to 100, tamoxifen 20 to 140. Aromatase inhibitor, when there is obesity, because of peripheral aromatization, estrogen becomes more, testosterone becomes low. Letrozole helps in improving the sperm count by decreasing the estrogen and increasing the FSH. Now, there have been patients who have been tried with idiopathic infertility using REC-FSH for 300 IU. Now, these are particular type of patients from, say, a Muslim, Bori Muslim community. They come to you for only IUI treatment with male infertility. There, you do not have any other choice than recommending them with this particular therapy. Again, HMG or highly purified recombinant FSH or SCG can be given. Some of them are basically used for hypogonadotropic hypogonadism, which we will be talking next time. Estrogen receptors. I had read one paper on clomiphene cited. The one particular center had clomiphene used for 3 to 4 months, and from initial count, actually they became azoospermic. Okay, and then after stopping the therapy, the count became more. So little variable reports. So we have to use it with not much expectation. Lifestyle disorders, now this is something which is I found very, very interesting in this paper, that if you are drinking more than 4 to 5 coffees per day, there is lack of X or Y chromosome associated with 1 to 6 copies. With additional chromosome 18, means you're in the sperm, these things can happen. Wearing boxer underwear can increase the number of whole chromosome 18. Obesity associated with additional number of chromosome 21. Psychological stress and prospective study, this study which we are right now conducting, that shows that these infertile men are having high associated comorbidity like varicose veins, hypertension, diabetes, obesity as compared to fertile control. Obesity is linked, as we know, obesity will cause suprapubic fat that will cause heat. Both the thighs are touching, so heat is produced, and because of your peripheral aromatization, there is low estrogen and low FSH, so they go in male hypogonadism, and which is cause of infertility, and also they have low sex drive. Now, as far as lifestyle is concerned, most beneficial with weight loss and exercise, have to stop smoking. If patient is smoking, then your outcome is going to be bad, and alcohol in moderation. I saw this weight reduction program excellently seen during COVID time, where the patient had no choice of ART treatment and they lost about 15, 20, 30 kgs during 1 or 2 years, and the count I saw raising from 6 million to 24 million, and spontaneous conception was seen. Small RCTs for the antioxidant, very inconclusive, are acupuncture, mind body, scrotal cooling. Still there are many people advising scrotal cooling treatment. Short abstinence. Now, repeated ejaculation, 20 to 25% reduction in the sperm DNA fragmentation just by having abstinence of 1 or 2 days. Again, with male factor infertility, what I do is a day prior to your ICSI, IVF procedure or oocyte retrieval, I tell the male to ejaculate the sperm, and next day I collect the sample in 1 day abstinence. Okay, so that way I am reducing the sperm DNA damage by reducing the duration of sperm spending time during the epididymal transit. This is an abnormal sperm. So this study, 118 patients with poor sperm quality was told to do ejaculation 7 days, no other drug, no lifestyle change. They found 80% showed improvement in the sperm parameters and 20% showed decrease in the sperm quality. Antioxidant therapies, you see pregnancy outcome improves, DNA fragmentation decreases. The only problem with antioxidant is there is no fixed antioxidant which will give a far better result than the next one. So what you found from this particular 4-5 studies, that more mitochondrial energizer, means the one which improves the mitochondrial function, L-carnitine in the dose of 2 grams per day, and coenzyme Q10 at least 200, supported with vitamin C, selenium, vitamin E, lycopene. I have my own reservation, and most important, folic acid, B6, B12 are very important. So we can have combination. Again, new combination of antioxidant paper from 2022. Again, sperm count improves, progressive motility improves, total motility improves, pregnancy outcome is something very different. So from this study, we know level A evidence is in coenzyme Q10. See the doses, 100 to 600. Now, when you select a combination, it's generally 100 milligram only. Now, all that nonsense, ubiquinone and reduced form and oxidative form, all has to be forgotten. You have to have 200 milligram, then L-carnitine B grade evidence, N-acetylcysteine, hardly any combination in India has N-acetylcysteine. Then you have vitamin C and ginseng and everything. So now a new molecule, myo-inositol, can improve the sperm motility and performance in OATS patient in vitro and vivo studies. So what it does, it acts on the sperm membrane, and it's a basically multivitamin which causes improvement, precursor of neurotransmitter. It improves the osmolar properties of the seminal fluid, and low osmolality decreases the motility and viscosity of the sperm. So significant increase in the sperm motility was found after treating with myo-inositol, but the dose is 2 grams. Again, the problem of with us is we give 500 milligram, maybe 1 gram can be given. Then comes the new kids on the block again. Now we talked about probiotics in females, now in male. Both these are live organisms which help work as an antioxidant and improve seminal microbiome by producing antimicrobial enzyme, immunomodulating response, and inhibiting the bacteria. So by adding these two probiotic, they found that the result improving the motility, sperm concentration, morphology. In my practice, I use this particular drug, especially in a prolonged male infertility, diabetic patients, and also patients having high viscosity. Now, another factor which suffers is when you have a count of 20 million, but A grade motility 0. Can be because of genetic abnormality where all sperms are immotile, like Kalaman syndrome. Anti-sperm antibodies, I still have to see a case positive, but you can treat them with steroids. Structural damage of the sperm because of the sperm tail, microscopic, varicose, and most important is idiopathic. We do not know. Maybe treat with doxycycline and it will help. The drug Viagra can be used 50 milligram 2 hours prior to ejaculation. Lot of papers in vitro and vivo has been published to improve the sperm motility from 28% to 37% in this particular paper by giving this particular drug, which is very, very useful in patients with severe OATS where the motility is hardly 2%. By giving this drug, you are increasing to 4%. Your embryologist is going to be very happy. Now, this is our own study done at our center where single dose sildenafil citrate was given to patients, and what we found that in 6 weeks time we collected one sample and the second sample and look at the motility, initial and the later on motility, rapid progressive motility. So both parameters improved. I used a lot of sildenafil in my patients in planned relations to improve the motility and to reduce the pressure on the men. So it helps in improving the sperm motility. But only thing it can cause the early capacitation of the sperm can happen. So that we do not know that long-term giving that will help. No other phosphodiesterase inhibitor has been shown to produce this kind of result, like tadalafil or anything. Only sildenafil has shown to produce this effect. Male obesity, we know that we call dysfunction, and there is a role of pediatric surgery. But in our practice, if you tell something about pediatric surgery, patients run away. I have a very important message to give. In 2017, I had seen a patient who was around 140 kg. He was very young, 30-year-old, and wife was also. I told them to go undergo pediatric surgery. They did not agree. After 1 year, they went under IVF. All embryos were fragmented. After first embryo transfer, patient never followed up. Just 3 months ago, wife called about the embryos. We said the embryos are still there. We asked them how are they. She told me that her husband has expired because of potential obesity complications. Another interesting intratesticular PRP. Now PRP has come in male factor, the regenerative potential. Lot of studies have shown increased progressive motility and concentration and decrease in DFI and increases the growth factor of PRP. So this particular study, when one failed TISA and one at least two failed micro TISA, after giving PRP, they found good results in both the groups. Well, right now it is very, very early to say. It all depends upon your patient selection and how do you do the procedure. This is our own one paper where pre-procedure secondary male infertility, the count was only 1 million, and this is the pre-PRP count with FSH of 18. You see, there are hardly any sperms in this field. This was done at least 4 to 5 times. You could see only one sperm here. See this? Severe OATS. Now, after doing PRP, the same patient, you see the motility of the sperms. See? So much improvement. The count became 4 million. Motility becomes 10%. FSH has come down to 9. Now, this patient can be taken up for IVFHC. This is, I have done till now 4 cases. Other 3 are in the waiting period, so we'll have to wait. So couple with OATS, look at how long they've been married, how long they've been trying, and severity of OATS, psychological factors. So surgical correction, you do surgery only if wife is normal or he's got repeated IVF failure. Young patient, you try medical therapy, empirical therapy, severe OATS, straight go to ART. Male infertility, medical treatment, surgical treatment, repeat semen analysis after 3 months. The problem is we don't want to wait for 3 months because we are scared that the patient will go to somebody else. This is the biggest challenge we are facing now. If there is improvement due to IUI with gonadotrophins, no improvement, IVFHC. All the treatments should be evaluated after 74 days of treatment. Surgical management, varicocele ligation. Sir, मला अजून 10 मिनिटं लागतील. Varicocele ligation.
Take your time.
Grade 1, grade 2, no surgery. Only antioxidants therapy can be given and followed by IUI. Only in varicocele where there is grade 3 to grade 4 varicocele, the sperm count should be at least 5 million with normal FSH and no testicular atrophy, or the patient will produce very good result, as varicocele will cause hyperthermia, apoptosis, hypoxia, increase our reactive oxygen species, and if associated with smoking, then there is 10% increased risk of oligospermia. Age-old method, subinguinal microsurgical approach is the best. With loop, it can spare the lymphatic and testicular artery, and it will help to ligate the veins below the magnification. So, microscopic spontaneous pregnancy 41, when there is no much improvement in the count, patient still will become pregnant, and recurrence rate is only 1%. With all other things, recurrence rate is very high. The recommendations are in adolescent guy with progressive testicular failure, you can do it. There is no evidence of benefit of varicocele with normal semen analysis. Varicose should be considered with oligospermia or duration more than 2 years. There is a paper on redo varicocelectomy in abroad, and they found still improvement in the parameters. Now, IUI in male infertility, when you use letrozole CC, your pregnancy rate is 7.7%. Moment you go to HMG, it is 13%. So minimum criteria, total motile count post-wash should be at least 1 million with 30% motility, and that will give you better result. Most common indications are erectile dysfunction and ejaculatory dysfunction. Now, in our clinic, for this particular issue, if there is no consummation of marriage, we do and teach them self-vaginal insemination by doing ejaculation at home for 6 months and then treat mild to moderate seminal alternation and idiopathic infertility. Intrauterine insemination for male infertility, time intercourse IUI is better. Mild hyperstimulation does not increase that with oral medication, but if you use gonadotropin, instead of one follicle, you try to get 2 or 3 follicles, it will give you better results. There is no difference found. This is a little older study between whichever technique or semen preparation you do. What they found, post-wash count has to be at least 1 million. Then comes cryopreservation of sperm. This is very, very important in terms of before radio and chemotherapy. The only problem here is this is will be kept in your IVF center for very, very long period of time. So you'll have to maintain the papers correctly. Secondary testicular failure, FSH is rising. Husband not available at the time of IUI, but the consent has to be taken before he flies off. And decrease anxiety. This is most important. Many patients find it very difficult to do the semen collection on the day of IUI or IVF pregnancy. If they have kept 1 or 2 samples, generally I found they do not have difficulty in collection. So cryopreservation before chemo radiotherapy, donor insemination program, OAT patient and absence of male factor. Now for donor insemination, azoospermia, ejaculatory dysfunction, failure of severe various IVF procedures, genetic defect, HIV positive, Rh negative woman, relative or known friend, our government says yes. Whether you want to allow, you say yes, but you route the sample through the sperm bank. Don't take it in your clinic. Everybody got it? So you send the same person to ART bank. ART bank will enroll him as one of the candidates. They will give their number of that sperm sample. On the day of the procedure, you ask for the same number and you do the IUI. So for you, you do not know it is a known person. For them, it is known person. So your liability would be low, according to me. And it is ART bank's responsibility of the giving donor sample. And generally we have height, weight, and complexions. So for donor, counseling is very important. Husband HIV, HCV 3 months, well-informed consent at every time of insemination. This will not happen that you have done a donor insemination in January, you've taken consent, will work for February, no. And you'll have to preserve the consent form. This is where I end my today's presentation. The rest of my presentation, I will do it next time, where I will talk more about OATS, new drugs, new techniques to improve the IUI outcome, and azoospermia. Thank you, sir.
Thank you so much, Kedar, for a wonderful presentation. Is Kundan there? Kundan, are you there? I would have loved Kundan to actually be moderator for the question answers that have come on the in the chat box, but I'll take it from here. So there is one question, Kedar, which says, how do we do this PRP? PRP exactly kaise karte people want to do?
So that is what is very important, that you have to do a PRP, you have to evaluate the patient correctly. This is what happens when you get a tool in your hand. You think every patient is for PRP. our previous president of Foxy, Dr. Jaideep Tang, would always quote this, and I'm quoting for on his behalf, that any new drug comes in the market, okay, you will think my grandfather also will benefit by this drug, and you will try on your grandfather. After 1 year, you will find that you will not even give to your dog. Okay. Then after 6 months, some smart chap will do a meta-analysis and tell you, actually it is required only in this patients. So wait for this to happen because it is still not FDA approved therapy. That is what I would like to tell everyone. It is not an FDA approved therapy. I have done with patients' consent and video consent and written consent in their handwriting that if anything goes wrong, they are responsible. But all patients' backup sample I have taken.
Just out of curiosity, somebody wanted to know how exactly it is done. I mean, इथे म्हणजे centrifuge करेंगे, get the sample, and how do you inject? Where do you inject?
What I did was I injected in about 26 to 28, 28 to 30 number needle, and I injected only 0.1 to 0.2 cc in multiple locations in the testes.
Okay.
Okay. Now, previously people injected large amount, which can cause a lot of edema and a lot of pain in the testes. After knowing that only I did this, and my patient did not have any problem. And I give them that hernia or hydrocele ka wo jo they give no bandage, scrotal bandage. I gave them that and 5 days of antibiotics and nothing.
Patient insisted on a general anesthesia or something for that, or some sedation?
The problem is I do not know how to give the block, the cord block. I am not confident. So I only took general anesthesia.
Otherwise, this could have been done with a block, right?
Yes.
Another question that has come from the audience, Dr. Khandare, which says, now you talked about short abstinence. That is one thing which will decrease the DNA fragmentation. But many times we find that, especially those labs which are owned by pathologists, when you send a patient for semen analysis there, they say 3 days of abstinence, उसके बाद में ही हम लोग semen analysis करेंगे. So now what do we tell? Is it a good practice to have a 3 days of abstinence before analysis is done, or there is no need for that?
Once the patient comes back from the laboratory, you send him the PubMed publications and write a clear-cut note on that prescription. I want to do an analysis on day 2 or only day 2 abstinence. That's all. Correct. You put your foot down.
Yeah.
If they are not ready to improve, they are not ready to get knowledge, they are still old dated. We still see semen analysis thinking of 40 million and 60 million, isn't it?
Yeah.
Reference value. So what can you do? You only way is this way.
Yeah. So what I do is I tell my patients कि अगर उन्होंने पूछा कि 3 days abstinence रखा क्या है तो तुम हाँ बोल दो, झूठ बोलो, लेकिन get the thing done. And nowadays I have started sending my semen analysis in an IVF center only, because that's where they do it in the proper way, and the sperm motility count is also done. Now, you were talking about DNA fragmentation index. तर कुठल्या cases मध्ये do you send this? And before that, when you were talking about the WHO criteria, since we are at it now, slowly and gradually, I find over the years, the criteria is now becoming less and less stringent. Is it because the sperm counts all over the world and the sperm, all the parameters are becoming lower and lower? Why is it now the WHO is every year thinking कि आपण आता will make it less stringent?
So first of all, I will put it up a similar example of diabetes. Dr. Walke, you have seen.
Correct.
First postprandial was 180, fasting was 120, correct? Up to
Correct.
120 was okay. Now where it is gone, 140 postprandial and fasting 100. Now these patients have become pre-diabetic. Without even we realizing it, these patients have become pre-diabetic on some evidence.
Yeah.
Whether this is correct or wrong, I do not know. Now, in this WHO, the major flaw has been very less number of Asian population is included. Is
Okay.
basically from European population. And again, the same thing is going to happen from 40 million to now 16 million. All these patients have become subfertile.
Oh.
By doing that. So we have to treat them now.
So you talked about sometimes the count being low, but the DNA fragmentation was nice. I mean, that index was good for us, and they cause more pregnancies. So now, has the time come that when you send the patient for semen analysis, you do the DFI also along with
No,
that?
no.
Routinely nahi karne ka na?
No, don't do as a routine practice. Only selected patients who refuse to take a medical therapy, or you have seen there is a varicocele, or there is associated diabetes, obesity, advanced age, or repeated failures. I will repeated failures. You should do a DNA fragmentation. Now, the DNA fragmentation test, the best method is tunnel. But tunnel technique is not available with us. So we are doing the most inferior test, which is done in our laboratory, which can vary from lab to lab. I have seen patients report a 68% DNA fragmentation. So sometime sir, consider this way. By identifying DNA fragmentation high or low, is my therapy going to change? So I am still going to give them antioxidant. I'm going to give them lifestyle. I'm going to do ICSI. I'm going to use sperm sorter. I'm going to use, repeated ejaculation as a technique. So I hardly use DNA fragmentation in my practice, but I thought everybody should know.
There is one question by Dr. Kandare. If you find that Y chromosome microdeletion is there, then how do you proceed?
Means, as I told you, that last Z zone is there, means it's a severe OATS, means you have to freeze the samples. There is no need of doing any medical treatment, and patient has to, if want to have a child, has to straight go for ICSI with proper clear understanding that if a male baby happens to him, that male baby will also have Y chromosome microdeletion. And if that is happens, then they should be told that they should tell the son to deposit the sample when he is 16, 18, 20, 21, because as the age will progress, his sperm count will become low and then become ageosperm. That is the only relevant thing. Other than that, there is nothing.
Yeah. So this is
I have not seen a paper where there is a correlation between Y chromosome microdeletion and ART outcome is ICSI or Y chromosome microdeletion and DNA fragmentation. I have not seen.
so that is only to guide the couple to tell the son to do cryopreservation of his sperms, because later on in life he may become infertile because of that. Right. Then there is a question by Dr. Margi. If sperm count is normal, A and B grade motility is 0, but C grade motility is 10%. Normal forms are less than 1%. And if IVF and ICSI is planned, IVF or ICSI is planned, now because you told us that the sperms from the testes are better than the sperms that are obtained from ejaculation, then would you use ejaculatory sperms here or would you use testing?
See, the first IVF cycle, first of all, I will try to find out why there is A and B are absent. So I will do hypoosmolar sperm function test to see how many percentage of sperms are live. Okay. If I get only 15% sperms alive, okay, which is tells me that my embryologist is going to have a tough time in selecting the sperm, then it's better to treat him. Find out whether he's got diabetes, obesity, antibiotics, probiotics, Sam Dam Danda Bhed, everything. And with Viagra, I'll repeat his sperm count in my clinic and see there is progressive improvement in his motility. I don't give more than 50 milligram 2 hours prior, that's what final. And if there is an improvement, then I freeze the semen sample. Okay. Now, whenever you get a sperm sample, now there is a new, this thing is called sperm mobile. Okay, it contains theophylline. So that can be added to your sperm preparation, which will, like a pentoxyphylline, it will improve the sperm motility of the whole your process sperm, and you will get a better chance of selecting a motile sperm than non-motile. Now, if this patient has got repeated 3 IVF failures in the past, then I will take the testicular sperm. Again, I will put them into this sperm mobile, identify the motile sperm, pick them up and do ICSI with motile sperm only.
Right. Thank you. There is one question from Dr. Tonde. There are two questions, in fact. The first one, we take it first. How many days of abstinence before IUI? That's what she wants to know.
On the day of SCG trigger, I tell the couple to be together and I call them after 36 hours for sample collection.
Correct.
And
so short abstinence.
Yeah, short abstinence. This is a primary rule in my clinic. 4 times a week you have to perform.
Okay.
Go to your great grandfather. No lights, no internet, no Netflix, nothing. After 7 p.m. sunset, kids will go to sleep. Only entertainment program was wife, so they had 25 kids. How did they have? They did not have any problems. Why are we having problems? You are sleeping at 11 o'clock. You are turning that side and seeing Facebook. And you are turning here and seeing the reels, dance. How it will happen, sir? It's become very difficult now.
Correct. This has become a lifestyle problem. So
yes,
at least we have to, as IVF consultants, impress upon them the importance of repeated intercourse. This is the least that we can do. Whether we can manage their
sometimes it is, you hear their stories, you will understand. I was hearing somebody's story. Their wife leaves at 7:30 house, comes home at 7:30 in the evening. So 12 hours are gone. After remaining 12 hours, she has to prepare food, feed everybody, clean up everything, and then again sleep with the husband, and then again get up at 5 o'clock in the morning to do everything. Are we not asking too much from the wife?
Yeah.
And the major problem of not having intercourse is in between the years. Mentally they are tired. They're tired of everything.
Correct.
When they come home, they want to have dinner, use their mobile for 20, 25, 30, 1 hour, and just go to sleep. That's all.
Yeah.
They live only on the weekends, sir.
Yes, unfortunate. Unfortunate that today's word is like that. Another question from Dr. Tonde says, can we give report of semen analysis performed on new semen analyzer machine? Is it legal? He wants to know. Semen analyzer machines ja आहेत. So can we give a report on that?
Yes, you can. Why not?
Yeah.
The only thing is what I found when some of the patients with motility in AI based this thing is low and count is high. Because according to me, the AI cannot differentiate between the pus cell, debris, and sperm.
Correct.
So that can tend to give false positively high sperm count, and motility it tends to give low. So I am not using that. I am still using the age-old method of manual count.
Yeah,
But,
because
But this can be very good tool nowadays. What I have heard in market now. This is from IVF perspective. All of you are going to practice IVF tomorrow. So by this AI based this thing, no, there are people are convinced on this basis that you will need ICSI.
Okay.
Understood. And that becomes a tool for you to convince the patient to take up for ICSI. I have heard.
Right. So it's like auto analyzer being used for the blood test and the hemograms, and you find that when the pathologist sees, then he sees a mega karyocytes, and otherwise you've got a report of a very low platelet count. So it's always important that though you may have done it on a semen analyzer, at least have a look before you gave the report off. So that is a correct message that you have given, and I open this. This forum for anybody to unmute himself or herself and ask question directly now, because the questions in the chat box are over. So anybody wants to interact with Kedar, this is a good chance to ask him questions, because the next time you will meet him in person, maybe in some conferences where he is also busy. So I would want people to ask him questions directly. And this is a forum where you can ask even the silliest of the question. Doesn't matter. This is not a conference that you're going to be exposed. That itna silly question kaise pucha. So please go ahead, open up your this thing, unmute yourself and ask the questions. Anybody wanting to ask? Monali has come for the first time on our platform, Zoom platform. Monali, you want to ask something?
Yes, sir. Sir, you were talking about the motility test. Where is it done? I mean, who does it?
Hypoosmolar form function test, your embryologist should be able to do it himself.
Oh,
it's not
okay, they can do it at any place?
Or in your IVF center, or you need a microscope,
okay.
And you need a normal saline to do the test.
Okay. And how about that Y chromosome microdeletions? Is it done if you ask for a simple karyotyping? Will they report it if it is present, or you need to ask them for particularly this? You have to see for this thing.
Karyotyping is different. Y chromosome microdeletion is a separate test.
What you need to ask the lab then?
Y chromosome microdeletion.
You have to write it like that only.
Yes.
Okay. How much that cost?
But do it only in severe OATS.
Yeah.
Not all OATS. Anything count more than 5 million, do not give them this test. And normal FSH, don't give. Below 5 million, you give this test.
Is it advisable to do this test before posting the patient for IVF then? Those are having the count less than 5 million. Is it advisable or not?
Means advisable or not means, as I told you, for counseling sake, you can do it. Okay.
Okay.
But otherwise, it's not necessary, because I told you again, by giving any medical therapy, this count is not going to improve because the cause is genetic. It's like thalassemia. If the patient has beta thalassemia, how much ever iron you give it, her hemoglobin, is it going to come about 10? No. So similarly, by giving antioxidant, you are just emptying their pockets. It's better that they go for ICSI directly. Unless there are associated factors like diabetes or varicose or is extremely obese, then you need to correct. Okay, Manali?
Yes, sir. Thank you.
Yeah. Anybody else wanting to ask a question? So if there are no questions, I think we'll close here, and we'll be waiting again, Kedar, for the next part of the lecture, which you said you will take after 2 weeks. So we'll post it in such a way that 2 weeks from the Wednesday that comes after the next Wednesday, we'll have your talk, so that there will be a continuity in the talk. So thank you.
Even I think that all these doctors should, if they have a particular topic which needs to be covered
Yeah.
in male infertility should be, they should write to you, and
Yeah.
I should be informed so that I will be able to pick it in the next.
That's what I'm planning to do now that they've heard you for this topic. I am going to ask their responses as to what now more you want to know about this topic also and any other topic, so that you can formulate your next talk accordingly. So I'm going to do that. We'll connect with all of them. So please do respond and write to us. You can connect with Kedar also directly and get what you would want to listen to from him in the week to come.
Hmm.
So let me thank all of you for joining, and let me thank Kedar for this wonderful presentation. I was told that this presentation is going to be mind blowing. I that is what Kundan told me, and let me confess, Kedar, this was really wonderful. And I'm looking forward to the next lecture. In fact, I'm more and more excited. Why, if this had happened about 15 years back, then I would have also taken up IVF. But see, at the fag end of my career, and when I'm 64, you people are giving me so much of information that I'm getting excited that I should also have started an IVF center. Uh, no, nevertheless, now I feel satisfied in mentoring juniors to take up this IVF center, and I have people like you, Kundan, Samida, and many others in the faculty list to instigate and to stimulate the youngsters to get into this practice of IVF. So I thank you, Kedar, for this wonderful presentation. And until the next Wednesday, let's say goodbye.
आपले सर आहेत का
मधुर सर.
मधुर सर.
मधुर सरांच्या वडिलांना काहीतरी प्रॉब्लेम होता, त्यामुळे ही गेव मी अ मेसेज दॅट ही टुक हिम टू अ हॉस्पिटल. इज देयर एनिथिंग यू वॉन्टेड टू कन्वे टू हिम? नाही, त्यांनी मला आत्ता फोन केला की मला अर्जंटली त्यांना घेऊन जावं लागतंय ज्युपिटरमध्ये. सो सो दॅट्स व्हॉट इट इज, राईट?
ओके, थँक्यू.
Okay, thank you very much.
Thank you,
Bye
sir.
bye. See you next Wednesday.
Thank you.